Alright, well, we are now a few days into Epic, so congratulations or good luck, however you may have. I know several people have already done one or several shifts, and now that we're a few days in, I'm just making this a second video to talk about two things. One is items in the chart that are required, information I've heard from the doctors, and the second is from my own point of view, just different ways to optimize your time about the chart and the software. So right off the bat, I'll just kind of show you one thing. When you go to Northeast or Bixler, there's different environments, but if you go to the top left, you click Epic. The first time you have to, go somewhere different, you'll do change context, and you'll just enter it and search up, Bixler or Northeast. But once you've done that at least once, you can go down to recents and favorites, and it'll be right there, and that way it just saves you a couple clicks, and it goes a little faster. So we'll start here at the tracking board, and you'll see that there's a bunch of different tabs. Some of it's kind of helpful, like the patient and their complaint, but some of it is just kind of a lot, and it really makes the thing clunky. So if you click this wrench icon just to the right of all these tabs, go to this wrench, and I'm just going to kind of walk you through how I've set up my chart or my board. You can obviously do it however you want, but the first thing you'll want to do is just kind of look at this list, and so some things are just very unnecessary, like some of it's for the nurses, so it has no relevance to us. Some of those include the unacknowledged orders, the to-do, the vitals, the pain. Some other stuff is like this patient RAD status. That's what the radiology technicians, I think, use to identify who's ready for like CT or what needs to be done. We don't have any need for that. I think there's one called note status. This new one at the bottom, there's new. I think there's one called, on our version, there's called best. Some people thought it has to do with whether there's a best consult, but it's for something different, so you can delete that one too. I think ours is called LOS, but this is like the total time, so that one can stay. But what I do is I also moved the attending or the doctor's name, the nurse's name in the APP. I've moved it closer to the patient and the age. That way you're not kind of scanning back and forth between the board on like, okay, is this patient been seen yet, or which patient do we need to go pick up? So what I did, I moved doctor, APP, and nurse all towards the left side of the board. I keep the complaint and the acuity right around there. I think I moved mine like this. I kept lab status because that just shows you what labs need to be done. Same with RAD, and I think there's EKG as well. I think the only one I'm not sure if it's on this version or not, but there's a comment box. That one's good to keep around, just so we can communicate between the patients and the nurses and the doctors. And then something you'll need to do, let's just say this said pod 1, and this is like pod 2, pod 3, pod 4, all the way through. What you need to do is do apply changes, and that way it'll apply it to everything else on your board for that day. Otherwise, if let's say you're working in pod 1, the next day you're in pod 2, if you didn't do that, it'll go back to that original view, and you're going to be confused. You'll also see when you're in Bixler, there's like Northeast tabs, and vice versa. When you're in Northeast, there's Bixler tabs. While those are on there, you can't see them, so what I'd recommend is just you can pull them down here, and those tabs will go away. And that way it just kind of frees up your board a little bit, makes it just overall a little less clunky. So you're welcome to play around with that how you want. Alright, so now we'll look at some more chart-specific stuff on the individual patient. So we're going to use this patient in this case. Right off the bat, if sometimes there's the question of who the patient's primary is, can be especially important for admits. If you go by their patient kind of information up here and you highlight over, it'll show it right there. So as long as the nurses update that, then that's where you can find it. So we'll look at the note stuff, and maybe your doctor's already had their note preferences, maybe they're still trying to figure it out, maybe you're just kind of want to know for yourself what the different sections are. So I'll just kind of walk through what I find helpful or not really relevant after using it for a few days. So we'll just kind of copy all this just so I can kind of walk through things. So okay, anything that begins with this begin note, anything that includes that, that'll just, once it publishes the chart, it'll just mention, so hey, HPI. This one down here says history begin, so that's what those mean. So I'll leave this one in. The ED chief complaint, that's what the nurses put in triage, so I leave that as well. That can be helpful. If you want to put your little kind of scribe by one-liner, recommend you doing that. This SF HPI, I recommend leaving that in there. It'll be a little more easier just to demonstrate on a future chart, but just leave that in there. I'd also recommend, if you start your HPI, we all kind of start them with the age and gender. So you can do that if you want to, put in more. So you can do that if you want. I tried that and I ended up finding it a little distracting, so I just leave it like that. But it can just save you a few things, especially on a busy day, that can be helpful. These are all the scores. I think I talked about the scoring tools tab in the last video. I personally find it somewhat helpful, but I've heard a lot of the docs kind of make some complaints about it. They say it's not helpful, so I'd recommend taking it out. And it's even if nobody puts a score in, I've seen this one on some chart. There's just like a random, like the HPI, and then at the bottom it's like GCS 15. So if anything, it's gonna be a little distracting or not relevant. So I'd recommend taking it out. And if you happen to, it's a chest painter and you used the scoring tool, use the heart score, and you want to throw it in somewhere, you can always just do whatever the score name is. So .heart score, or we have the NAHSS. So you can always just phrase it in later, but I just take it out, so it's not automatically implementing random scores in. All these right here, it's just not really helpful right now because every patient, it's probably their first time. Maybe people are already coming back, but everyone is essentially new to Epic. Even if they're importing charts from Cerner, it's all new. So right now, a lot of these automatic history stuff just says negative, 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 and I just kind of find it, again, not very helpful. Maybe down the road it can be more helpful, but for now I'm just taking it out. I'll leave in this ROS begin because, again, that just shows on the chart once it's published there's a new section. This is where you can just put in your little otherwise negative, however your doctor wants that to be phrased. That way it'll automatically be in. You don't type it every time. We then go down to the PE begin. There's a template about vitals. I don't remember what this one's called. It might just be .vitals. I don't personally find it helpful because it doesn't update. Even if you try to update it later, it'll only show the first obtained vitals, and maybe the nurses put an error. Maybe someone came in with this respiration or this heart rate of 22, and maybe it was either an error or now they're just better, but you can update it. So I think it looks a little weird. So what I recommend is just delete it. Whatever the dot phrase is in there, just take that out, and then you can put in .vitals all. That way, once the nursing staff has updated the vitals, you can refresh your chart and it'll show you, 2, 3, multiple vitals. I think they're just better overall. So this physical exam, if your doctor uses the interactive one with all the clicks and kind of the, more interactive version, you'll want to leave that in. But if your doctor's using just kind of how it was on Cerner with the blank generic text, just, copy whatever it is. You can still access Cerner for a few days to just say, whatever your doctor's exam is, just put that in there. I'll leave the MDM begin in here. The ED course, whether you've worked with it or not, it can be pretty helpful as you're especially updating, or the doctor's kind of updating themselves on the vitals or the imaging. They might do it, you might do it. I think everyone kind of has access to it in a chart. I personally find it helpful at the bottom, and I'll demonstrate that on patient later. I think if it's at the top, it kind of conflicts stuff at the end. I don't know what this is. I think that's just on this version. I don't think that should be in our TMH version. But whatever this second line is, I'll take that out. You'll want to leave in this MDM 2023. It'll be important later for some billing related stuff. I can explain that again later. But if your doctor's using anything like a differential line where they want to put a differential diagnosis, or if they have like a shared decision-making statement, whatever that may be, or if they have something else like cardiac monitoring, I personally find that the best under MDM begin, but above the other stuff at the bottom. So we can just do that and just call this, just adult note. Adult note. Okay, I already made one. I'm doing this the second time, so we'll just say adult note 2. Okay, so then we'll just kind of back up, pretend like we didn't spend all that time doing it. So let's say it's already made. Pardon me just making things redundant, but we'll just delete that. And then we can insert what we want from smart phrases. So that way it it's things we want and things we don't want. Obviously, again, follow what your doctor wants. You can also play around with it a little bit, before shift or after shift. So the reason I left that SFHPI and that MDM23 is that you can then click them. That kind of makes the things a little easier to get to. I took out the ROS because, again, most of these doctors just use this one, and if your doctor does use a physical exam and you leave that fancier version in, you'll see it in there. But if your doctor's using just the text, then it'll just be HPI and MDM. Your HPI, you can either type it from here if you want, or you can just type it at the bottom directly. So there's kind of no specifics on that. Either one works. The MDM is where it gets important. That's why we left it in. If you're writing the rationale, it should go in here. It has to go to the billing stuff, the way that LOS calculator works out. You'll want to leave it, type it in here. It's possible to type it on the side on the right. You could type it there, but for some reason it just won't calculate that way. So Dr. Ho said, type your rationale in this narrative up here. And then you can, if anyone else added to the story, just type these in. If you do if your doctor's ordering tests, make sure both of these are being clicked, ordered, and independent interpretation. If your doctor wants you to put the results directly in this box, you can do that. If they're doing the ED course, it'll be, down here at the bottom. You can either just do a generic one like x-ray shows, yada yada. That'll count. Or there's nothing ordered on this patient, so you can't do it. But let's say he had a chest x-ray ordered. You can click on chest x-ray. A little icon will flash at the bottom, and you can also put in your, chest x-ray shows. So either way, if you do it through the workup, you go back to your note writer and you just make sure that it says details documented in the ED course. So multiple ways to skin that cat. Now this patient came in with a laceration. Let's say he cut his leg. Most docs, I think, will want to do their procedure note, to keep it all in one chart. It is possible to go to my notes tab, find this procedure, and create the note. However, then it makes like 2 charts, which should theoretically be combined later, but the much simpler version, which should still count, is you just kind of stick it wherever you want. My guess would be under physical exam and before MDM. If you do proc doc, that'll automatically throw in a new procedure section, and you can find, there's a lot of the common things, and then procedures over here. Let's say it's a laceration repair, and the PA or the nurse practitioner on for the day does it. Just type their name in. I don't think there's any in this version, so I won't. But you can do that as performing provider, and then leave your doctor as authorizing provider. Now, one thing is regarding critical care. There was a confusion whether we have to put it in here for it to count or not. I think the thing right now is, if your doctor wants it in here, from what I've heard is, you put the time, so the 35 or the 75 or whatever it may be. Supposedly, all these buttons don't need to be clicked, just this one. If your doctor wants more things to be put in, that's fine. Just kind of talk with them about it. But let's say we do that on the critical care. Then you go to Dispo, and at the bottom, the doctor. This might be more for doctors, and if you're doing it with your doctor, that's fine. If this is not what you're doing, just disregard. But the doctors have to put this level of service charge. 1 is very simple, 5 is complex. If they do critical care is almost like the 6th button, which we don't see on there, but critical care is this 99291. They can click that, and there's no diagnosis with this guy. I didn't throw one in yet, but that's what it would be. You would do critical care, it's not a level 5. It's theoretically like a level 6. So, but you can either throw it in there, or your doctor can just bill. You click charging and then select level 6. But let's say we did that. Let's say he's also getting a laceration repair. You can throw that in there as well. And then let's say he's going home. So now we're going to talk about this Dispo tab. Again, talk with your doctor if you're comfortable doing this. I don't think it's very complicated. But let's say you're going home. We'll do discharge. You select a condition. If the patient's up for a conditional discharge, so like let's say he's just getting some IV antibiotics, just say after IV antibiotics. But otherwise, you can just leave it blank. The impressions will be laceration. You find just a random thing. Probably should have been a little more specific, because again, if you're very generic, it'll just kind of come up with everything. So just try to be more specific when you're searching. It might save you some time. So you can do left or whatever. And on the discharge, the patient education, the handouts, if you click discharge, an icon will flash up below the impressions. It'll say patient pass. It's not showing up here, but you could search on patient pass for like wound care or laceration repair or whatever. There's the instructions on the right. It's a little deceiving. I think that's all for inpatient medicine. From the ER, there's no discharge instructions. So again, if you do the discharge, look for patient pass. You can also do follow-up, so their regular doctor. And this is kind of cool. It was where Epic gets pretty intricate. Let's say this guy happens to have a doctor at Shands that he needs to follow up with. Search by city first, and then on our version there'll be specific doctors, so you can type up. But here you can always just say it won't have specific doctors, but you can follow up with his doctor at Shands. So even though they're not in Tallahassee, it's kind of interesting that it'll pull doctors from other cities. If you can't find it, that's fine. But if they have another doctor's name and they know they're like, hey, I'm seeing him next week, it just kind of shows that we're being thorough. So if you do that, it doesn't have to be done, but it can be done. So that's kind of how that all works. If they're getting admitted, you just do the admit, of course, and obviously there'll be stuff that the doctor does because they handle the admits, we don't. So you can always do admit. One more thing about the discharge. At the bottom, once you click discharge, there's this final step. In the old version of Cerner, people called it putting the house up. So if you've heard that term before, that's what that means. But this one is at the very end. Once everything's done for them, the doctor's already reevaluated them, that's that ready to go. And if it's not done, on the left side, their icon will be purple. But then once you do that ready to go, it'll turn them to a nice green, or maybe a not nice green, whatever you find that. Anyways, changes the color, and that's kind of the indication that they're done. They can go home. So when you're with a note, when you make a note for the first time, there's this share button on the bottom right. Share really means just save. So on Cerner it said save, but really it's share. So people have asked me about that. So if you're made a chart, you're ready to move on to another one, you'll want to come back to it, you can do share. And that way you can go to other things, and let's say you want to come back to it, you can do my note. And you come back, and let's say you're kind of just ready to wrap it up. Everything is, you're working on everything, and you're ready to go. You can always do ready to view, and it'll send it to your doctor. Some people up here, if at the top, there's this cosign required. If it's there, you can type your doctor's name in. I'm gonna do that. If it's not there, don't worry about it. Some people don't even have this option. It's just forced on them, and other people it's forced not on them. But just kind of if it's there, I'd recommend just throwing your doctor's name in there. And then when you're done with it, you can do ready to view, and that's kind of sends it to them. That's our version of sending. And let's say you do it and you're like, oh no, I meant to throw something else in. You can go back and do it, but if you look at the bottom, once you send it, it says this note documented by. So every time you send it back, the ready to view, if you do it 6 times, there'll be 6 lines of this. If you do it once or twice, no big deal, but try to limit it, because that way, I don't want 20 lines of saying note documented by. It just doesn't look well. So when you're still working on a chart, just do share. When you're ready to send it, do that ready to view. And then you can look on notes that, let's say at the end of your shift, you say, I don't know which ones I still need to work on or which ones I'm done with. So you can go to My Incomplete Notes up at the top, and it'll have all the charts you've created. And what you can do is, you can, let's say this is the one we just worked on, so you can click on it, and I'd scroll through, and I might see okay, note documented by. That means I send it to the doctor. That must mean that I'm done with it. I would still check just to make sure I'm not missing anything big, but you can do that. And then let's say there's another one, I'm looking wow, I didn't put anything on this. I need to really go back and work on it. You can click on edit note, and that'll pull it back up, even if they've been discharged. So one more thing I'd recommend doing before you send a chart back to your doctor, just refresh the smart links. That way if there's any new results, or if the diagnosis is in there, it'll pop up on the smart links. So that's most of it. Again, I recommend when you're editing your templates, I recommend putting the ED course at the bottom. Otherwise, let's say this is our rationale. We're talking about whatever the rationale may be. If we leave ED course above that, oftentimes the doctor will put their reevaluation note. So it might say like patient improved, like discharge home, and I'll just accept that. So, let's say then someone's reading the chart and they read the HPI, they read all this information, they read the physical exam, and then right after the physical exam, it's, like the first thing they see is patient improved discharge. They don't even read the rationale. So, in my place, that looks out of order. That's why I'd recommend, again, when you go back into that editor and you build, if the rationale down here is like, hey, we're going to do like chest x ray, labs, yada yada, if that's all at the end, that doesn't make much sense to me. So, I'd recommend just on your editor, you can do it one time, and then it'd make more sense of, again, you're reading through the chart, you read the physical exam, you get to the MDM and the rationale, and then after that is when you start to read results and discharged home. That's just how I recommend things. If your doctor doesn't want to do that, totally up to them. I just say communicate with them, make sure you're doing what they prefer, not what I prefer. So, and then again, when you're right before you're ready to send it, I say just refresh, make sure everything's in there, and then you can do ready to view, and it'll send it to your doctor. So hopefully that just kind of explains a little more. It for some reason doesn't disappear stuff when you've sent it. It'll pop back in, so that's a little frustrating. But again, you can kind of just scroll through each chart quickly, just see is anything big missing. Otherwise, if you see your note has been documented by, that tells you you've sent it to your doctor. So that's kind of your marker for what still needs to be done or not. If you have any questions, you can reach out. If you've learned anything cool that I've not talked about that you think other people would find helpful, please share it. Otherwise, just keep trucking along.